Now that we've been introduced to our white blood cells, let's talk about leukemias. I like to think of leukemias as the instance when white blood cells misbehave. In the past, this was our last unit in white blood cell, but I feel like students have often struggled with this unit, so I decided to put it toward the beginning of our lecture series, simply to give more time for studying before the final exam of our white blood cell unit. When categorizing leukemias, we typically categorize them under two subsets, the first being acute and the second chronic. Originally, these were based on the life expectancy of the patient who had acquired or who had these leukemias, but now we really look at the level of maturity that we see in each individual case. In chronic leukemias, we tend to see more mature cells, and in acute leukemias, we tend to see the least form of maturity in the form of blasts in higher populations. So there are a couple of characteristics for both acute and chronic leukemias. Typically, acute leukemias can occur in all ages, but usually it has a clinical onset that is quite sudden. Normally, if untreated, acute leukemias have a life expectancy of less than 6 months. The leukemic cells that we see, both in the bone marrow and in the peripheral blood, are immature forms. Anemia could be mild to severe depending on the aggressiveness of the disease. We're going to see things like thrombocytopenia, and in the case of acute, we're going to see mild to severe thrombocytopenia as well. Acute leukemia, we tend to see a more variable white blood cell count, so it may be either very high or very low, or it may even look normal initially. And then we may have some organomegaly, which just means inflammation or enlargement of the spleen, liver, etc. And that could be mild in acute leukemias. However, in chronic leukemias, we typically see a more adult demographic. We may have an insidious clinical onset, which just means it kind of creeps up and then progressively gets worse over time if left untreated. It's usually less aggressive than acute leukemias. So chronic leukemias, if left untreated, a patient could survive 2 to 6 years and maybe even beyond that. We see a more mature form in those leukemic cells. The anemia that we do see in chronic leukemias is mild in comparison to the acute leukemias. Again, mild thrombocytopenia. However, in the case of chronic leukemia, we typically see a very, very elevated white blood cell count. And we also see a more prominent organomegaly, so more prominent inflammation or enlargement of various organs. Okay, so with regard to leukemias, there can be a variety of different causes, the first one being viruses. The first virus that we're going to look at is that Epstein-Barr virus. So Epstein-Barr virus is a DNA virus associated with Burkitt's lymphoma. And if you recall, that both Epstein-Barr virus and Burkitt's lymphoma are associated with our infectious mononucleosis that we talked about in the last PowerPoint. There are a couple of other viruses, and this is called human T lymphotropic virus, and that is HTLV1 and 2. Now, HTLV1 is RNA associated with adult T cell leukemias and lymphomas, so it crosses over and infects the T cells, causing them to become abnormal in terms of their proliferation and activity. And then the HTLV2 is linked to atypical hairy cell leukemia, and we will get into more detail about all of those in further on. Another cause could be environmental causes such as ionizing radiation or chemicals such as benzene, anti-neoplastic drugs, and that actually includes chemotherapy drugs. A lot of patients who receive chemotherapy for a neoplasm of some sort may actually get a different type of cancer down the road due to that chemotherapy exposure. However, most of the time we have patients who relapse, it's typically the same type of cancer. We may have genetic defects such as Fanconi's anemia, and we'll talk a little bit more about that as we get further in. So leukemias go through something called transformation. Leukemia usually starts with a single cell and goes through 2 or 3 more steps, maybe more, resulting in a clonal proliferation of cells that eventually replace normal bone marrow cells. So what we're looking at is a proliferation of one type of unhealthy cell, or rather one type of the same kind of cell, so that those ratios of normal to abnormal cell proliferation becomes irregular within the bone marrow. Usually that transformation occurs at the pluripotent stem cell level, but sometimes it does occur later on after a committed stem cell with a limited capacity for differentiation has already gotten to that phase of development and then just becomes proliferative in that particular cell line. So a lot of people who develop leukemias or who are later diagnosed never know that they have a significant illness or serious illness until they become symptomatic. And that's because leukemias cause suppression of normal blood cell formation and organ infiltration. This may result in the failure of normal hematopoiesis, resulting in things like anemia, thrombocytopenia, and granulocytopenia. Organomegaly of the liver, spleen, and lymph nodes is very common, and depending on the type of leukemia or proliferation that you have, the area of organomegaly is going to differ. We may have things like petechiae, easy bruising, mucous membrane hemorrhage due to that thrombocytopenia. So again, decreased platelet count will interfere with our ability to clot. We may have a prominence of bacterial and fungal infections due to that neutropenia. So if you think about what we just talked about 1 second ago, that granulocytopenia, and you think about the number of granulocytes we have and what proportion of those are neutrophils, that's going to be significantly reduce our neutrophil count, which of course are the primary defenders against bacterial and fungal infections. So that neutropenia is usually pretty serious for patients with leukemia. Flu-like symptoms such as weakness, lethargy, bone and joint pain. And then of course we're going to do additional testing because we have to really narrow down what's going on in the body in vivo. We're going to do chemistry testing, and a lot of those chemistry tests may come back abnormal. We may see things like an increased uric acid and LDH due to high cell turnover, and increased serum due to bone resorption in things in cases of multiple myeloma, where we might even see radiology changes in those bones. Okay, let's first talk about acute leukemias. Now, if you think about our cell lineages, we have our myelocytic lineage and then our lymphocytic lineage. And just like our two lineages, either one of those lineages could develop acute proliferative leukemias. So the first type of leukemia that we're going to talk about is ALL, or acute lymphocytic leukemia, and of course that is going to be through our lymphocytic cell line. And we classify acute leukemias utilizing a classification system called the FAB, and that stands for French American British classification. In the terms of ALL, we use classifications L1 through L3, and we will talk about those details in just a moment. In terms of AML, because we have more types of myelocytic association or involvement with AMLs, our classification, although it's still through the French American British classification system, is a little bit more detailed. We may have different cell lines of the myelocytic lineage involved, and so we have a more extensive classification system of M0 through M7. So what we're going to be looking at in terms of diagnosing an acute leukemia is we are going to be looking at the maturity. And what we're going to see in acute leukemias of both ALL and AML are predominantly blasts or of either myeloblasts or lymphoblasts or promyelocytes or prolymphocytes. It is more aggressive. It is a quicker onset of disease, and unfortunately, patients with acute leukemias tend to have a worse prognosis than those with chronic leukemias. So, how do we know if something is an acute leukemia versus a chronic leukemia? I mean, aren't there blasts in the bone marrow? Yeah, there certainly are, but there is a normal and acceptable ratio of blasts within the bone marrow. And in the case of acute leukemia, in general, bone marrow exceeds what the normal level of blasts would be. So in this case, equal to or greater than 30% of bone marrow cells must be immature for a diagnosis of acute leukemia to be considered, and specifically blasts. So that 30% is going to be the magic number in considering a leukemia acute versus chronic, because there are chronic leukemias that transition into acute leukemias over time. And so really that's going to be the line that we draw in the sand and say, okay, this is a chronic versus an acute. And it's really when we're seeing greater than or equal to 30% of those bone marrow cells as blasts. Now, acute myelocytic leukemia, or AML, is a cancer of the myeloid white cells. It's characterized by a very aggressive and rapid proliferation of abnormal cells. And those cells accumulate in the bone marrow and really interfere with the production of normal blood cells. So we're going to start to see a decrease in normal ratios, normal proportions, and normal cells overall. And of course, AML is the most common acute leukemia affecting adult. And as we get older, its incidence increases with age. In terms of our lymphocytic leukemias, our acute lymphocytic leukemia, often referred to as ALL, is a cancer of the lymphoid white blood cells. And that is characterized by an overproduction and continuous proliferation or continuous multiplication of malignant and immature white cells. We call these lymphoblasts. So this is going to be the very least mature form or the most immature form of those lymphocytes. And we're going to see that in the bone marrow. And again, that magic number is going to be equal to or greater than 30%. Because of its aggressiveness, it is fatal if left untreated. And as ALL continues to proliferate, it spreads into the bloodstream and other vital organs very quickly. We see acute lymphocytic leukemia, or ALL, more commonly in children than adults, although we can see it in adults. This is the primary leukemia that affects children, and it's much, much, much more common in children than you would ever see in acute AML. Although AML can affect children, primarily when a patient has an acute leukemia and they're a child, I would say statistically speaking, it would be an ALL. So let's talk a little bit about differentiation. In terms of cellular development, when we are at a myeloblast or a lymphoblast phase of development, there's really no way to identify what type of cell lineage that comes from. And in acute leukemia, most of the cells are blasts, and those are very difficult to classify into the lineage of the cell by morphology alone. And so, therefore, we really have to find other means of identifying what lineage or what type of leukemia, acute leukemia, our patient has. So in the past, we have used cytochemical staining and immunologic cell marker studies, aka flow cytometry. And we really need those to differentiate between ALL and AML, because when you look at a blast, it's very difficult to know, is this a myelocytic or myelogenous line, or is this a lymphocytic? If we do have an AML, cytochemical stain and flow cytometry also helps us differentiate between the subtypes, because remember, we have many different types of myeloid cells, and each one of those types of cells, or a mixture of one or more, could be the proliferative problem. So you may have like a monocytic leukemia, AML, or you may have like a myelomonocytic AML. You can see those different subtypes come into play. And the reason why it's really important for us to be able to determine what type it is, we can treat it based on the subset or the subtype. So here are a couple of pictures. We've got ALL on the left. These are all going to be lymphocytic lymphoblasts. And then we have AML on the right. And honestly, they're very difficult to tell which one is myelogenous and which one is lymphoid. So that's why these tests are so important in terms of cytochemical staining and flow cytometry as well. All right, so let's talk about cytochemical stains. What is it that we're looking for? Well, because lymphoblasts and myeloblasts are really difficult and actually impossible to differentiate or to identify by just looking at them, we can do a few staining tests that really pick up and show some of the characteristics that are present in their blast form. Now, for example, staining called TDT, or terminal deoxynucleotide transferase, is a lymphocytic cell marker. So all cells from the lymphocytic line will stain positive in ALLs. But if it stains negative, we know we're not looking at a lymphocytic line. We are looking at a myelocytic line. So TDT will be negative in all AMLs and positive in all ALLs. Now, Sudan black B, or SBB, stains the phospholipids within granulocytes, and it may also weakly stain monocytes. Now, if you think about granulocytes and monocytes, they come from that original progenitor cell, and they are in the same branch of the myelocytic branch. But because monocytes are technically agranulocytes, because they don't have those primary and secondary granules in the same way that, or at least in the same abundance as other granulocytes, they aren't going to pick up the stain as well, because they simply just have less of that myeloperoxidase present. But it's going to stain those enzymes that we found in that primary granule of the granulocytes. And if you think about it, when we went through characteristics of white cells in our introduction to white cells, we did talk about some of the enzymes that were found in the primary, secondary, and tertiary granules of the myelocytes. And myeloperoxidase is one of the enzymes that is found in the primary granules. So in the presence of myeloperoxidase, it's going to stain, and we'll be able to identify that at least as a myelocytic line of blast. The CAE, or chloral acetate esterase, sometimes called NASD or specific esterase, is specific to granulocytes. Doesn't stain monocytes, it just stains granulocytes. And remember, even though monocytes and granulocytes are kind of related from that earlier progenitor, granulocytes are granule, and then we have monocytes, which are technically considered an agranulocyte. Next, we have NSE, alpha naphthyl butyrate, or a non-specific esterase. Now, this is going to stain a few different things. It's going to stain monocytes, megakaryocytes, and strangely enough, focally on T-cell lymphocytes. So that's the only one where we have involvement of both lymphocytes and myelocytes. So that's kind of why we call that one a non-specific esterase. Next, we're going to have one called ACP, or acid phosphatase leukocyte. We call this the trap stain. With and without tartrate to diagnose hairy cell leukemia. Now, hairy cell leukemia is a kind of a rare condition, and this trap stain is specific for hairy cell leukemia. And we're going to talk all about that in just a bit. The PAS, periodic acid shift, stains glycogen, and that's going to be positive in all ALL and in AML category M6. So I guess what I just said was NSE was the only one that had myelocytic and lymphocytic, but in actuality, PAS also does. We've got all lymphocytic, acute lymphocytic leukemias, and then AML, M6. And we're going to talk about those classifications in just a bit here as well. Here's a chart to kind of help break down our lymphocytic leukemia T and B cells. These are just going to be immunoglobulin gene rearrangements. I'm not going to get into too much depth in terms of the T and B cell until we get to a little further down the road. But yeah, this is just really a nice little table to take note of. So again, with regard to our ALL, or our acute lymphocytic leukemia, we are going to classify using that French American British classification system. We are kind of moving away from the FAB classification system to the World Health Organization classification system, although it's perfectly acceptable and still commonly used for French American British classification. And over the next few years, we're going to be implementing more of that World Health Organization, but it's still kind of in transition. So the first type of classification is called L1. Those will be small uniform cells, which are dominant. We're going to have nuclear chromatin that's homogeneous, so it's going to be very smooth chromatin, no clumping. We're going to have a nice regular nuclear shape. We may have occasional clefts or indentations. And then the nucleoli, or those clearings within the the chromatin of the chromatin of the nucleus, are few, small, round, and also homogeneous. The cytoplasm is going to be scanty or mild, only mild to moderate basophilia, and variable cytoplasmic vacuolization. The second class is L2. We're going to see in this category large heterogeneous cell size, so they're going to be varying in size and larger. We're going to see nuclear chromatin that's also heterogeneous, and then nuclear shape is irregular with clefting. We might see large nucleoli and various irregularities within the chromatin. Cytoplasm is going to also be variable, and often abundant vacuoles may be present in some cells. And then L3 is finely stippled and homogeneous. We might have a nuclear shape that's regular, round to oval. We will see nucleoli that are prominent, one or two, and cytoplasm is moderately abundant with deep basophilia, and we will see prominent cytoplasmic vacuolization. Whereas in L2, we might see some abundant vacuoles, but not prominent. And then in L1, that cytoplasmic vacuolization is going to be variable. You may see it, you may not. It may be small, it may be large. Okay, now that we've introduced ALL, or acute lymphocytic leukemia, let's introduce AML, or acute myelocytic leukemia. You may hear AML called by a variety of different names: acute myeloid leukemia, acute myeloblastic leukemia, acute myelogenous leukemia, acute myelocytic leukemia, acute non-lymphocytic leukemia. These names are all interchangeable and they all mean the same thing. All right. So the classification for AML, or acute myelocytic leukemia, is a little bit more complicated than the FAB classification for ALL. So let's kind of talk about what makes each classification different and what we are looking for. The first category or classification of AML is M0. This is going to be called myeloblastic without cytologic maturation, and we're going to see minimal differentiation here. This is kind of a rare category or classification, but it is a very poor prognosis for those patients that do have it. They're going to stain negative for all cytochemical stains, and the reason for that is because there's minimal differentiation. We're going to see fewer of those granule specific, or those granules that are specific to certain myelocytes. We're also going to have, in terms of flow cytometry, we will have positive cell markers for CD13 and CD33. The next category for AML classification is M1. This is called myeloblastic without cytologic maturation. So we're going to see about 90% or more of those granulocytes in the bone marrow are myeloblasts because, again, we're not going to see maturation, but we will see a little bit of maturation, so about 10% of our cells. And then greater percent of the peripheral cells are going to be Sudan black B positive and that myeloperoxidase cytochemical stain positive. So remember, those cytochemical stains are going to help us identify what type of cell line we're looking at. They will also be positive for CD13 and CD33. M2 is the third category, and these are going to be myeloblastic with maturation. So very similar to M1, but we're going to see a greater amount of maturation here. So it's going to occur beyond the myeloblast stage. So we might have up to 89% of blasts in the bone marrow, but we're also going to have some chromosomal abnormalities that are specific to M2. And this is going to be a translocation at genes 8 and 21. These cells in this category of AML will be positive for monoclonal granulocytic markers CD13 and CD33 as well. And this is the most common category of AML that we see. So if you look at M0 through M2, they are all going to be positive in flow cytometry for CD13 and CD33. And those, of course, are granulocytic markers, so that would make sense. The third type, or I guess the fourth type or category of AML is called promyelocytic hypergranular. And what we tend to see in this category or classification of AML are a conglomerate of fused primary vessels forming an intracellular body that we call Auer rods. And we usually see these Auer rods in high quantity throughout the cytoplasm. And we're going to look at some pictures in just a bit. The problem with M3 is that because the granules that are present in the promyelocytes are higher in thromboplastic substances, it can actually cause abnormal clotting. And so this particular category or classification of AML runs a higher risk of DIC. Now, we haven't really talked too much about coagulation, but what DIC is, it stands for disseminated intravascular coagulation, and it's a coagulation consumptive disorder where It's actually a hypercoagulable state, but because that hypercoagulable trigger causes rapid disseminated abnormal clotting, it utilizes all of the resources, utilizes up all of the platelets, utilizes up all of the circulating coagulation factors, and now leaves us depleted. So it presents as a bleeding abnormality. And so it's just a very, very dangerous and highly lethal condition. And if it isn't diagnosed and determined to be DIC quickly, that's probably not a very good prognosis for the patient. M3M is promyelocytic microgranular. So we've got a difference in the granularity between M3 and M3M. And we're going to see indistinct granules with a characteristic notched or bilobed nucleus. This also has an increased incidence of DIC. And the abnormalities that we see in terms of chromosomal translocations are going to be on loci 15 and 17. Okay, so this is going to be our second most common classification in terms of M4. We see some other chromosomal abnormalities, trisomy 4 and plus 4, and the variety of deletions and translocations on 11q23. This is going to be non-specific esterase positive. And we might see elevated serum or urinary lysozyme in this classification of AML. So most of these have had to do with monocytes or maybe other granulocytes, but there are some that are associated with eosinophils as well. And we know eosinophils are granulocytes, but these are specific to eosinophilia. So M4E is going to be M4 with bone marrow eosinophilia, and this is going to be an increase in those eosinophilic blasts. This is going to be associated with an abnormal Q16Q karyotype, and of course, obviously, a blast is a blast is a blast. We wouldn't really be able to determine that this is associated with eosinophilia until we get back our cytogenetic testing, which tells us that this has an abnormal 16q karyotype. M5 is just plain old monocytic AML. And we're going to be looking at CD markers 14 and 11B. They will both be positives. The monocytes obviously migrate from extramedullary sites in the skin and the gums. So what we're going to see is bleeding, swollen gums. And if you think about it, that's what monocytes do. So you have an overproliferation of monocytes. Their nature is to go into circulation, look for infectious agents, and then migrate out into the tissues where they have specialized jobs in whatever tissues they become residents in. But monocytes are just doing their job, but there are so many of them. They're so overly abundant that it becomes problematic. And then we're going to have that serum lysozyme. This one is also associated with DIC, so problematic in terms of causing thrombotic problems as well. And then chromosomal abnormalities are going to be a translocation at 9 and 11, not 9 and 13, 9 and 11. M5A is poorly differentiated monocytic AML. And about 80% or more of all of the monocytic cells are monoblasts. So we're going to see blasts of a monocytic origin, but they aren't going to be well differentiated. Whereas in M5B, monocytic, well differentiated, we're going to see 80% or less of all the monocytic cells are monoblasts. So that 80% is going to be kind of a key there, differentiating between M5A and M5B. A couple more categories that are associated with red cells, and then with our platelets or megakaryoblast. And if you remember, all of these cells, the red cells, so the erythrocytes, the granulocytes, the megakaryoblasts, monocytes, all of those come from the same progenitor cell and then differentiate out into the different branches. So don't think that don't think it's too strange for us to have an erythrocyte associated AML because technically red cells are myelocytic in origin. So M6 is called erythroleukemia, and this is where we have dysplastic erythroblasts. Now, when you hear the term dysplastic, it just means that there's something broken in the production process. It's not making them right. So something is wrong in production. I always think of dys as like poor or like dysfunctional, and then plastic being made. So what we see are these dysplastic erythroblasts with multinucleation. So we're going to see more than one nucleus sometimes. We might have cytoplasmic budding, and it's kind of just like a little weird projection into the cytoplasm, vacuolization, and megaloblastic changes. Now we talked a little bit about megaloblastic changes in a red blood cell unit. So we're going to see enlarged cells. We're going to see things that just aren't looking normal and maybe a little oversized. Next, our red blood cells are of all stages of maturity must compose of equal to or greater than 50% of the nucleated bone marrow cells, and 30% of the other cells must be myeloblasts or promyelocytes. And then we are going to check it for glycophorin A. Remember, glycophorin is going to be one of those proteins that we see in our red blood cells. So that's one of the ways of confirming that these are of the red blood cell line or the erythrocyte line. And then M7 is going to be our megakaryoblastic. We're going to see 30% or more of cells are of the megakaryoblastic lineage in the bone marrow. And remember, these are in the bone marrow. Bone marrow aspirate may be unattainable due to marrow fibrosis. And we're going to talk about fibrotic marrows coming up in our myelodysplastic disorder unit, but just know that that's essentially where the bone marrow becomes kind of crunchy and hard and fibers run through it, so it doesn't have room for all of the nice soft hematopoietic bone marrow tissue or that red marrow. We might even have circulating megakaryoblasts in peripheral blood, so super kind of weird looking megakaryoblasts, and then glycoprotein 3A positive as well. So each one has kind of a hallmark that we want to really just keep our eyes open for. So we need to know what are translocations that are associated with each classification, the cytochemical staining, maybe some of the normal or abnormal chemistry tests, and how often we see this. Is this the most common? Is this second most common? Is this associated with other types of problems like DIC? So really it's just important to know all of the things that make it a hallmark. And just a reminder, take a look at your online hematology atlas. That is where you're going to get a lot of great pictures. We will go through some of those as well in class and talk about each one. So just to recap our AML versus ALL, let's talk first about demographic. AML is more common in adults and less common in children, although children can have AML. ALL is more common in children, and we don't see it as often in adults, but again, there are always exceptions to the rule because white blood cells don't always follow the rules. With regard to our peripheral blood, we're going to see an AML anemia, neutropenia, Thrombocytopenia, we might see some myeloblasts and some promyelocytes circulating, so some immature cells or some blasts. And then in our ALL, anemia, neutropenia, thrombocytopenia, and then lymphoblasts. Now again, it's really, really difficult to tell the difference between a lymphoblast and a myeloblast, and that's why we have to go on to do other testing to be positive. But before we get to that, let's talk a little bit about the morphology that we would expect to see. So we might have medium to large blasts with more cytoplasm than the lymphoblasts have. We might have cytoplasmic granules. We may see hour rods. We might even see that fine nuclear chromatin and very distinct nucleoli. Now with ALL, we might see small or medium blasts with very little cytoplasm. We won't see granules in those. We may have fine nuclear chromatin and indistinct nucleoli. Now you might say, what the heck is fine nuclear chromatin? Well, it means smooth. It means that it doesn't look chunky. And the smoother your chromatin is, or your nuclear chromatin, usually that is a sign or an indicator of immaturity in terms of white cells. With regard to our cytochemical staining, we are going to have a positive peroxidase or myeloperoxidase in AML. We will have a positive Sudan black B and then a negative TDT for AML. And then for ALL, we will have a negative myeloperoxidase and Sudan black and a positive TDT. Now, there are other cytochemical staining patterns that we might see with regard to non-specific esterase and specific esterase, etc. But these are the primary ones that are kind of going to lead us in the right direction. So start out with myeloperoxidase, Sudan black, and then TDT, and that's going to kind of push you. And then use those specific and non-specific esterases and other tests there to kind of narrow it down to categorize it if it is an AML or an ALL. Extramedullary and focal disease. So it's going to be common in the spleen and liver, but less common in the lymph nodes and central nervous system. And we are also going to see in ALL common lymph nodes, spleen, liver, CNS, and gonads. So those are going to be kind of opposite in terms of AML versus ALL. All right, so with regard to leukemia, acute leukemias, these are aggressive, and so rapid diagnosis and treatment is imperative. So some of the general treatments that we use in acute leukemias is cytoreductive chemotherapy. Obviously, these drugs are utilized to kind of kill or knock down the proliferative cancer cells. We may use radiotherapy, and typically if there is central nervous system involvement, we try to localize that treatment so that we can maintain the integrity of the other tissues surrounding the central nervous system. And last but not least, bone marrow transplant. Now these are all kind of just general treatments, but there are some that are more specific depending on whether we have ALL or AML. With regard to ALL, we may use prednisone, vincristine, asparaginase, irradiation, and especially when CNS is involved. And then with AML, we might use a combination of cytarabine and daunorubicin. So the above treatments are aimed at achieving remission. And we define remission as the absence of detectable leukemic cells with peripheral blood and bone marrow counts returning to normal. Bone marrow may become hypoplastic or even aplastic. So if you think about it, if you're producing more than what you're supposed to produce, maybe you're a factory and you're working overtime, your instrument or your machinery is going to break down. And that's kind of what happens. The bone marrow becomes kind of spent. And in that case, patients are given hematopoietic growth factors to kind of stimulate and wake up that bone marrow. It's just so exhausted. And then pretty soon things will equalize or normalize. If not, bone marrow transplant is still an option for those patients. On the other side of the coin, we have chronic leukemias. We have CLL, which is that chronic lymphocytic leukemia, and then we have CML, chronic myelocytic leukemia. Now, we have another unit coming up called myeloproliferative disorders, and we will talk more about CML in the myeloproliferative disorders lecture. However, this is the one area or this one condition that can kind of cross over into two areas or two classifications, so to speak. So it can be considered as both a myeloproliferative disorder and a chronic myelogenous or myelocytic leukemia. So more on that later on. So what we see in chronic leukemias are predominantly mature cells. The problem is we just see a number or a higher number than is normal of any specific cell line. These cells, this proliferation is more gradual in onset than acute leukemias, but what we see is a very elevated white blood cell count. This is a more common condition, so chronic leukemias are more often seen in older adults, and they tend to have a better life expectancy overall. All right. So with regard to chronic lymphocytic leukemia or CLL, essentially we're looking at a clonal expansion of B lymphocytes, and these appear mature in nature. And that is in contrast to ALL, where we have the majority of blasts or lymphoblasts present. In CLL, this involves the lymph nodes and other lymphoid tissues with progressive infiltration of bone marrow and circulation into the peripheral blood. Remember, the reason why our lymph nodes and our lymphoid tissues are going to be involved is because if you think back to cell development in terms of lymphocytes, our lymphocytes spend a period of time in the lymph nodes and other lymphoid tissues for their final phases of development. And if we have an overproliferation of them, we're going to see signs of lymphadenopathy or swollen lymph nodes, splenomegaly, so our spleen is also a lymphoid tissue, fatigue, and then our other early signs will be a persistent lymphocytosis, which, as you know, is just an increased or an abnormally high lymphocyte percentage. Most often, CLL is seen in adults, and it has a higher prevalence in males, 2 to 1, although I see it in quite a few females as well. I do see it more often in males. This is something we see in the laboratory every single day. And a lot of times we look at a slide and we know without even looking at their chart that this is a patient who has CLL. Of course, we do look at their chart, we verify their history, and if they have no history, we then send it to be verified with our pathologist, who oftentimes will recommend flow cytometry, etc. As the disease progresses, even though this is a slow progressing disease, patients often suffer with chronic fatigue, recurrent and/or persistent infections, and easy bruising due to anemia. So again, CLL is a proliferative disorder of the B cell lymphocytes or the B lymphocytes, and with that proliferation comes crowding out in the bone marrow of other healthy cell lines. So in this case, we would have easy bruising due to a decreased number of platelets being produced. All right. So with regard to diagnosis, there are a few things or some criteria that we look at. We are going to look at the absolute lymphocyte count, and that is typically above 15,000 microliters. And then, of course, the normal is 4 to 10.8. We're going to see a normocytic normochromic anemia. So again, we would have a normocytic normochromic anemia because there's nothing wrong with the red cells that are coming out or being produced, but fewer of them are being produced because of that lymphoproliferation that's happening in the bone marrow. There's just not enough room and all of the healthy cell lines are being crowded out. About 20% of patients have autoimmune hemolytic anemia. Isn't that interesting? Their peripheral smear will have polychromasia and spherocytes. And then we may see something that a lot of people call soccer ball lymphs and smudge cells. So the thing about patients with CLL is as those lymphocytes are proliferated and as they mature and go out into circulation, they just don't look quite right. They have clumpy chromatin in the nucleus, and because of their kind of, if you think about cells in a three-dimensional way, because of that kind of roundness that they have, and that clumping chromatin, they have a fragility that we don't see in other normal lymphocytes. Um, that results in them smudging or basically rupturing, and then you just have, it looks kind of like a bug that someone stepped on right on the slide. It's just like a splat. And we'll see some pictures of that as well. Some people call them basket cells. Um, they call smudge cells basket cells. Some of them call them balloon cells, but the typical name is smudge cells. Okay, so looking at this picture, um, these two cells on the slide are B lymphocytes from a patient with CLL. Now, not every single cell in the patient's lymphocytic population are going to be very like this distinct. Some of them may look indistinguishable from normal lymphocytes, but the majority of them, I would say more than 50 to 60%, will have these areas of nuclear chromatin and these clumps here surrounded by these lighter areas of parachromatin, and these can sometimes resemble soccer balls. That's why we call them soccer ball cells. Now, if we were to come across a patient with CLL and we're looking at the slide, we might see those soccer balls or those soccer ball cells, but we might also see something that looks like this. It looks like a big splat, like somebody stepped on a bug. And these are called smudge cells. These are ruptured lymphocytes that are very, very fragile and break easily when a slide is made. So this occurs during the mechanical process of slide making. And we find this in much higher numbers in CLL patients. In fact, it's one of the clues that we might be looking at a patient with CLL who has not already been diagnosed. What we can do to give those cells a little bit more stability, durability, is we can take whole blood from the patient and add 1 drop of bovine albumin, which creates a protein matrix around the cell and makes it a little bit more sturdy. And then we can do a count based on that albumin slide. So we'll make a slide with that drop of albumin and then the whole blood mixture. Ultimately, it's about 1 drop of bovine albumin to 9 drops of whole blood from the patient sample. We then just mix it up and then we make a slide as we normally would with regular whole blood. All right, so CLL is kind of unpredictable. The life expectancy is variable from patient to patient, usually because there are other factors that come into play in terms of life expectancy. Your overall health, outside of your CLL diagnosis is going to play a big role. Lifestyle is going to play a big role. Um, Treatment compliance is going to play a big role. Um, but for the most part, our treatment in the beginning is usually supportive in the early stages, especially before we have that very, very elevated white blood cell count, before anemia becomes severe. So this is kind of just like a watch and wait. The doctor will monitor your disease state and kind of just see where you're at. But remember, this is kind of a slower progressing leukemia, and so a lot of times people can live with this for years and years. But later on, as the proliferation of those B lymphocytes increases, chemotherapy might be needed to kind of knock those cell populations down to allow healthy cell populations in the bone marrow to continue to thrive. All right, so hairy cell leukemia. This is This is a fun one. I think I've only seen this once in my career here, at least. And what we're looking at in terms of hairy cell leukemia are we're going to be looking at a mature B cell neoplasm. And this typically affects middle-aged males more than females. It can affect females, though. Pancytopenia is commonly presented in terms of symptoms due to fibrous bone marrow. So again, here we have another bone marrow that's kind of breaking down. And one of the hallmarks of hairy cell leukemia, hence where it gets its name, are these frayed cytoplasmic projections and the projections are kind of hair-like. They look like they've just got a bad haircut. One of the things that we do, and we talked about this in our cytochemical staining slide, is hairy cells are resistant to the tartrate in the acid phosphatase stain, or that trap stain. So that's one way that we can really identify a hairy cell leukemia from maybe just a lymphocyte who looks a little fuzzy on the edge for whatever reason. This disease is usually slow progressing as well and responds well to chemotherapy. Okay, so let's wrap it up. So here are a couple of pictures of a patient's sample with hairy cell leukemia. On the right, you see these cytoplasmic projections. They kind of look like hair, little hairdo here. They also do have a little bit of that clumped chromatin. And this is just with a regular right stain here on the right. And then on the left, we have that trap stain. And you can see they did not stain well. These are resistant to that trap stain. So this would be an indicator if we were to do a stain on this sample and these were the results we got on the left with that trap stain, we would be able to highly suspect that these are hairy cell leukemia cells. So obviously we would then refer it to our pathologist. They would probably order a flow cytometry, etc. But ultimately that would be kind of like a screening test or just, something to put us in the right direction or fill in the gaps of information. All right, so let's wrap up this PowerPoint. Thank you all for joining me, and best of luck in your studies.